At the best, I thank Dr. Vittal and Mapicon for inviting me and accepting my request for delivering a talk here. As a cardiologist, it is always, thrilling to present the cases from the cath lab, as Dr. Vishav has presented. And Dr. Vishav has presented such wonderful cases, even the computer accepted defeat. It did not work to run the few cases. But more important than presenting and more important than what we are doing in the cath lab, we have to understand that we are clinicians first. So in my next 20, 25, 30 minutes, I will be talking about the aspect of the cardiac disease, which because of the interventions either done by Dr. V.K. Bahal, done by other interventional cardiologists, has led to the onset and the increasing trend of this disease. The heart failure. Heart failure. The heart failure does not mean that the heart is stopping or the heart has stopped. What it means is that the heart is doing good for the other organs of the body at the cost of its own. So it is delivering or it is helping the body but hurting itself. Since the medical sciences, this heart failure, the concept of heart failure, the definition of heart failure has been there. And again we are discussing the same thing. Why we are discussing? Because of the increasing trend of the disease. And why it is increasing? Because more of the people, they are getting hypertensive, they are getting diabetic, obesity is at the increasing trend. The better options to treat the coronary artery disease, better tools for diagnosis, better detection and treatment of causes, and more importantly, almost any disease of the heart can ultimately lead to the heart failure. And with the modalities available for treatment of the heart diseases, increased longevity of the life, the incidence and prevalence of heart failure is increasing. So that becomes more important, that why we are discussing this heart failure. If we see to the burden of the disease, the 21 million adults worldwide, they are living with the heart failure, and it costs us around $108 billion. It is the number one cause of hospitalization in patients aged more than 65 years. And almost 100% of patients have associated 3 risk factors or comorbidities. And more importantly, when we talk of the mortality, the 50% of heart failure patients, they die within the 5 years from diagnosis. So if we diagnose a patient of heart failure today, irrespective of whatever treatment we give, the 50% of patients will die in next 5 years. So that is why we are discussing it again, and we will be discussing in the next decade, 2 decades down the line as well. If we talk of a prevalence, the prevalence in developed countries is about 2%. And in India, we are not behind that, it is around 1.87%. We don't have a set criteria for diagnosis of the heart failure. So it is all a clinical diagnosis. So it's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. And unfortunately, there is no single diagnostic test for heart failure, because it is largely a clinical diagnosis based on the careful history and the physical examination. And when we come to the diagnosis of heart failure, this is the classic Framingham's criteria, the major criteria and the minor criteria, which all, as the residents till date, we follow the criteria. And now we have the biomarkers also, especially in the emergency situations when we are not able to decide whether the dyspnea is because of the cardiac cause or it is a non-cardiac cause. Then we have the biomarkers in use nowadays which can easily differentiate between the two. These are the various risk factors. I will not go into this. Most of my talk will be based around the chronic heart failure. So if we come to the classification of heart failure, this is just for the residents that we have on the basis of the ejection fraction, the reduced ejection fraction heart failure, what we used to call the systolic heart failure, and the heart failure with preserved ejection fraction, what we used to earlier call as the diastolic heart failure. Similarly, we have classification on the basis of the time course, chronic heart failure and the acute heart failure, anatomically the left-sided heart failure and the right-sided heart failure, and by output, high output heart failure or the low output. If we come to the definition of heart failure, the heart failure with reduced ejection fraction, what we used to call the systolic heart failure, when the ejection fraction is less than 40%. So you do an echocardiogram in a patient and you find an ejection fraction less than 40%, so he fulfills the criteria of heart failure with reduced ejection fraction. The patient's having a clinical diagnosis of heart failure and you do an echocardiogram and you find that ejection fraction is more than 50%, so he falls in the criteria of heart failure with preserved ejection fraction. The third subgroup, where you do an echocardiogram and you find the ejection fraction is between 40 to 50%. This is the borderline area. They can be either the heart failure with reduced ejection fraction, where you have given the treatment and the ejection fraction is improved over time, then we label them as heart failure with preserved ejection fraction improved variety, improved subclass. Or they can be the heart failure patients of preserved ejection fraction who have slowly are going towards the reduced ejection fraction. So then we call them as borderline heart failure with preserved ejection fraction. This is the 2016 ESC guidelines depicting the same, that if you have ejection fraction less than 40% is in heart failure with reduced ejection fraction, heart failure with preserved ejection fraction more than 50%, and this is the borderline area. You can call it a moderately reduced ejection fraction. When we come to the differentiation on the clinical basis between the heart failure with the reduced ejection fraction and the heart failure with preserved ejection fraction, there is hardly any clinical parameter to differentiate between the two. But mostly the soft pointers, if you have a patient, male gender, if you have known cardiovascular disease, and on ECG you find a left bundle branch block, there is high probability that this patient is having a heart failure with reduced ejection fraction. On the other hand, if the patient is obese, associated with smoking, and there is an atrial fibrillation associated with heart failure, the chances or probability of heart failure with preserved ejection fraction is more. Another classification system of the heart failure is based on the stages. The stage A is that the patient does not have any feature of heart failure, but he has the risk factors present. And any risk factor for the coronary artery disease is a risk factor for the heart failure. So a hypertensive patient, or a diabetic patient, or an obese patient, or a previous history of coronary artery disease, or peripheral vascular disease, or a family history, any risk factor you talk of coronary artery disease, that becomes a stage A heart failure. So any hypertensive patient, he becomes a stage A heart disease. Any patient of diabetic is a stage A heart disease. Stage B is the patients have a structural heart disease, like they have suffered a myocardial infarction previously, they have suffered a coronary artery disease previously, but they are not symptomatic. So it becomes a stage B. So they have a structural heart disease, but they are not symptomatic for the heart failure. Stage C comes when the patients have a structural heart disease, associated with that they have the symptoms. So it becomes a stage C heart failure. And the stage D becomes a refractory heart failure, where they have marked symptoms not responding to optimal medical therapy. So this slide, I feel, for the residents it's very important, because when we are treating the risk factors, we have to understand that if we don't treat the risk factors, we are making the progression, making the person to progress from stage A to stage B. So any risk factor patient, any patient having a risk factor of hypertension and diabetes, we should treat this patient as a stage A heart failure. This is again correlating with the NYHA class. So this is the diagnostic algorithm of patients with suspected heart failure. If you suspect the heart failure, take the history, do Framingham risk scoring, do an ECG, and if you have an echo, then you don't need to do anything. Get an echo done and you will find whether the patient is having a systolic heart failure or the diastolic heart failure based on ejection fraction. If you don't have an echo, then go for the biomarkers like pro-BNP and BNP. If they are raised, then patient is having a heart failure. If they are not raised, that means the patient is a non-cardiac cause of heart failure. So this is a simple algorithm, and anyone can follow this. The prognostic factors, the poor prognostic factors in heart failure patients. Patient of heart failure with low blood pressure is a poor prognostic indicator. Patient of heart failure with previous coronary artery disease, poor prognostic indicator. Troponin release is very high, poor prognostic indicator. If on echo or on ECG, you find a broad QRS, echo you find a dysynchrony, poor prognosis. Renal impairment, if it is associated with the cardiac, with the heart symptoms of heart failure, poor prognosis. Hyponatremia. Any patient of heart failure with hyponatremia, prognosis is poor. Clinical congestion at time of discharge, less ejection fraction, raised BNP and pro-BNP, they are all poor risk factors, prognostic factors for the heart failure. So coming to the aim of therapy, when we are talking about the aim of therapy, we should keep in mind how to reduce the symptoms, how to improve the quality of life, how to reduce their hospitalization. Because as I've talked in earlier slide, it is number one cause for rehospitalizations in patients aged more than 65 years. And paradoxically what happens in our scenarios, that as we grow, as we age, we get retired from the routine services. So the source of our income reduces and burden of the disease increases. So this becomes a paradox. So we have to reduce the mortality, correct the pump failure, and prevent the sudden cardiac deaths. And more importantly, when we are in our clinics and treating with the patients of heart failure, we have to be human first, then we have to be doctors and then clinicians. We have to understand the person, because no guideline can teach us how to deal with the patient. The only thing what can make us understand how to deal with the patient is our understanding of humanity. So most of the times I feel, if you talk nicely with the patient, make him understand, give him some time and make him understand that it is not only the medications which are important, there are the other emotional aspects, the non-drug aspects which are very important. The dietary counseling is very important. If a person comes to us to you and says, what about, what should I eat and what should I not eat? You should make him understand what are the things you should eat, what are the things you should not eat, rather than saying jo marzi kare or whatever you want to do. The patient education is very important. Physical activity is very important. You have to tell them how much physical activity is required and how much physical activity should be done. Medication compliance is very important, because you have to make them understand that you have to live with the medicines. You can take 3 meals, but you have to take 5 medicines, 4 medicines in a day. So you have to make them understand about the medication compliance. Follow-up is very important, and you have to talk with your attendants about the sudden death of these patients. Because the heart failure patients, they are more prone to have sudden cardiac deaths. So when we talk of the heart failure, the treatment of the heart failure patients, there is a very wonderful slide wherein, the hurting heart is having an analogy with the donkey. The heart is like a donkey. It keeps on working. Whether you sleep, whether you work, whether during day or night, the heart keeps on working. Whether it is hurting itself or not, that's a secondary thing, but it keeps on working. So the heart is just like a donkey. It has to work all the time, from the birth till death. So these are the non-pharmacological routines which we should talk to the attendants. Activity, the diet control, the sodium restriction is very important. The fluid restrictions in fluid overload patients is very important. The sodium should be kept around more than 130, it should not be reduced. These are the things which we have talked. And when we talk of the pharmacological measures, we have the drugs for the acute heart failure and drugs for the chronic heart failure. Diuretics, vasodilators, and inotropic agents. I will be talking in coming slides about these things. So the rationale for medications, one should understand what is the rationale. You are giving the medicines to the patient, what is the rationale of giving the medications? If you have to improve the symptoms of the heart failure, you have to believe on the diuretics and the digoxin. And if you have to improve the survival and reduce the mortality, the beta blockers, ACE inhibitors, ARPs, they are the medications. So when we give the diuretics, what are the benefits? They improve the symptoms and congestion. They improve the neurohormonal milieu. They improve the cardiac output. But the limitations are the oral absorption is unpredictable. Access to, at times we give more of the diuresis, we keep on giving the diuretics and patient keeps on diuresis, keeps on passing urine. So we cause an excessive volume depletion in such patients. This is one of the limitations. Electrolyte disturbances, especially the hypo or hyperkalemia and especially the hyponatremia. So, and it does not have any effect on the mortality. ACE inhibitors, about 32 trials have been done till date in heart failure patients, and the reduction in mortality is well documented with the ACE inhibitors. You talk of Ramipral, you talk of enalapril, about 32 trials have shown the mortality benefits. This is depicting the same. So how the diuretics and ACE inhibitors work? They reduce the preload. They reduce the load on the heart. So the donkey has to carry less burden forward. So this is how the load has been reduced by the diuretics and the ACE inhibitors. So what are the recommendations for ACE inhibitors? Captopril, enalapril, lisinopril and Ramipral. These are the 4 ACE inhibitors which have been advised and recommended for treatment of heart failure. And you can go to the maximum dose of 10 milligram Ramipral, 40 milligram lisinopril, enalapril 20 milligram. The only thing is that you have to take care of the renal parameters. The only side effect, the commonest side effect which is seen with asthma is the dry cough. And most of the patients, they don't tolerate because of the dry cough. Coming to the beta blockers, again, the mortality benefit has been seen. And there are about 123 articles and 18 trials have been done for beta blockers in heart failure. And all the trials have shown a mortality benefit with the beta blockers. So what the beta blockers do, they reduce the speed of the donkey. So the preload is, they don't have an effect on the preload, but they reduce the speed. So they make him to relax more, work less. So that is the way how they help the hurting heart. So these are the trials we show the mortality benefit, be it CPS2, Merit, HF, Copernicus, whatever trial. The 3 beta blockers have been found efficacious in treatment of the heart failure patients, the bisoprolol, the carvedilol and metoprolol succinate. These are the only 3 beta blockers which should be used in heart failure with reduced ejection fraction. Bisoprolol 10 milligram maximum dose, carvedilol 50 milligram twice, that's 100 milligram. So most of the prescriptions, most of the beta blockers in the trials also, they have not been used up to this. But this is the recommended dose and this is the recommended how to titrate it. Start with a small dose and then titrate or increase the dose till you reach the maximum dose which is recommended. Metoprolol succinate up to 200 milligram. So if you can start from 12.5 milligram metoprolol up to 200 milligram in heart failure patients. Spironolactone, the mineralocorticoid receptor antagonists. We have spironolactone and eplerenone. Again, these are the only diuretics which have been shown to have a mortality benefit. The loop diuretics, the thiazides, they don't have any effect on the mortality, but the mineralocorticoid receptor antagonists, the spironolactone and eplerenone, they have an effect on the mortality. They reduce the mortality in heart failure patients. This is the eplerenone, definitely showing a reduction in the mortality. So when we talk of the aldosterone receptor antagonists, spironolactone 12.5 milligram, 25 milligram once till 50 milligram. Similarly, it is with the eplerenone also 50 milligram maximum dose. So the only problem with the MRA is that they cause hyperkalemia, especially when you are using along with the ACE inhibitors and beta blockers. So how to monitor this? Stop all the potassium supplements, check potassium and creatinine 2 to 3 days after starting then. After starting with MRA, you should check for creatinine and potassium after 3 days. Then after 1 week, then every month for 3 months, and then every month when clinically indicated. So first 3 months you have to cautiously watch about the rise in the potassium, because in heart failure patients there is an associated renal disease, and when you are giving the ACE inhibitors along, the chance of hyperkalemia are very high. So you have to be very cautious for the first 3 months as far as prescription of MRA vis-a-vis potassium is concerned. Digoxin is a time-tested medication in heart failure. None of the trials supports its mortality benefit, but believe me, most of the time is when we have nothing in hand, the digoxin works. I have seen in my clinical practice also, when nothing works, the digoxin works till date. So the only thing is that you have to keep in consideration the ACE inhibitor, this renal parameters in this scenario. So digoxin, it doesn't do anything to preload, it doesn't do anything to the afterload, it doesn't do anything to the donkey, but what it does, it acts like a carrot. So it keeps the donkey happy, that carrot is in front and go on doing the good work. So it is a more of a placebo effect, but definitely in clinical trials there have been reports that the hospitalization rates has been decreased, but mortality benefit is not there. So this is the digoxin. Hydralazine and nitrates, this was used in the black population especially, but in our population and Indian population, I don't feel there is much support to it, though there have been prescriptions which have come where the hydralazine and nitrates have been given the heart failure patients, but most of the trials which have been done in this molecule is on the black population, not in the rest of the population. So if we come to the guideline recommended incremental addition of treatments as heart failure progresses, so in the stage A, when the patient is having a risk factor, control the risk factors, whether with the lifestyle modification, with the diet control, whatsoever you want to do, but control the risk factors. In stage B, do what you want to do what you have done in the stage A patient, and then add the ACE inhibitors or ARBs or beta blockers, whatever is recommended. Stage C, go on adding the medicines as I have discussed and I will be discussing in future. And stage 4, that is the stage D, the options are extraordinary measures, heart transplant, chronic inotropes, permanent mechanical support, experimental. These seems all hypothetical. So this is again the same, the pharmacological treatment algorithm, how to treat the heart failure patients. Anticoagulation. Anticoagulation has not much role in heart failure with reduced ejection fraction or preservation unless until the patient has an associated atrial fibrillation. If the patient of heart failure has an associated atrial fibrillation, anticoagulation should be given. And in case of the paroxysmal or persistent atrial fibrillation, you should continue for at least 6 months. And if it's a permanent atrial fibrillation, then you have to continue for a longer time. So there are newer anticoagulants, dabigatran, you can use any of the anticoagulation depending upon the financial status of the patient or depending upon your comfortable, whatever the patient is comfortable with. Statins, we have been using statins in heart failure, but per se statins in heart failure, they don't have much role. Statins for heart failure, the aspirin for heart failure has nothing to do with the heart failure patients. But yes, if the coronary artery disease is underlying, then you can use the statins, you can use the antiplatelets. At present, the statin therapy should not be prescribed primarily for the treatment of heart failure to improve the clinical outcomes. Omega-3 fatty acids, these are the only nutrients which have been advised for the patients of heart failure, especially the omega-3 polyunsaturated fatty acids. These should be used in patients with heart failure. Other nutritional supplements like coenzyme Q, a lot of the pharma companies come with coenzyme Q, carnitine. These seem to be all hypothetical, just the marketing gimmicks. Otherwise, the only nutrient which has been found to be helpful in the heart failure patients is omega-3 fatty acids, polyunsaturated fatty acids, PUFA. So I have talked for the last 15-20 minutes, but this is the actual talk which I was supposed to discuss here. So what are the newer treatments in the management of heart failure? So this is the actual talk which I was supposed, but I thought that we should have a basic knowledge and then we can build our stories. Building cannot be built without knowing the basics. So once our basics are clear, then we can add on our more stories. Avapritinib, this is one of the medications which have been recently launched and recently tried in heart failure patients. SHIFT trial definitely supports that there is a reduction in the hospitalization in patients taking avapritinib. These are the three drugs, the intravenous iron, empagliflozin, and sacubitril/valsartan, what we call the ARNI. These are the three medications or three therapeutic options for the management of heart failure, which have been added in addition to what we have already discussed. Intravenous iron, in fact, we were also part of this trial, but this did not help much in the heart failure patients, and this is a class 2B indication for patients, especially for the patients of heart failure who have a serum ferritin level less than 100 and the HB is less than 15. So this is a class 2B indication for heart failure patients with anemia. So we were very enthusiastic when we started with this trial, but unfortunately we could not find good results with it. So maybe there may be other parameters to discuss, and then we can find the other results. We could not find much. Empagliflozin is an anti-diabetic medication. So it has come as a very good tool for the patients with heart failure. Why? Because it decreases the sodium reabsorption in the proximal convoluted tubule in kidney and exerts the diuretic or natriuretic effect. The sodium redistribution between the intra and extracellular volume components, and it decreases the extracellular volume of 5 to 10%. So it acts as a diuretic. At the same time, it reduces the HbA1c. It has a negative caloric balance. It decreases the systolic and diastolic blood pressure by 5 by 2 millimeter mercury, increases the fat oxidation, decreases the plasma triglycerides. So it's an never anti-diabetic molecule given for the diabetic patients, but fortunately and surprisingly, it has been tried in heart failure patients, and the outcomes have been better. This is the sacubitril/valsartan. What we I could not get to, sir. No, diabetic patients. Diabetic. It's a diabetic molecule. So this is the salt which we should discuss for another 5 minutes or so. The sacubitril/valsartan. If we talk of the medications in heart failure patients, the ACE inhibitors, they reduce the mortality by 16%. Beta blockers reduce the mortality by 34%. Mineralocorticoid receptor antagonists, they reduce by 30%. ARBs, in case ACE inhibitors are not tolerated, then they reduce the mortality by 17%. In spite of using this much, 50% of patients die within 5 years of diagnosis. So whether we use ACE inhibitors, beta blockers, MRE or ARBs in addition or altogether, still the mortality is very high. And if we come to the basic pathophysiology of heart failure, there's an activation, what we used to be taught or what we used to read at our times, there's an activation of the sympathetic nervous system and there's an activation of the RAS. So these were the only two which were being focused when we were doing our MBBS and MD. And this is the newer pathway which is being targeted now. That is the neuropeptide system. And during our DM times, this used to be targeted, but now it has been aggressively being targeted. And now we have a sympathetic nervous system blocker in the form of beta blockers, the RAS in the form of ACE inhibitors or ARBs, and mineralocorticoid receptor antagonists. And then now we have a newer association, that is the neuropeptide system. This is what I will be talking about. So neuropeptide system, what the RNA what I am talking about is combination of valsartan and sacubitril. Valsartan is an ARB, it blocks the angiotensin II receptor, and sacubitril, it degrades the neprilysin enzyme, which degrades the BNP. So once it degrades the neprilysin enzyme, the BNP level is increased. So BNP, as we know, natriuretic peptide, it is a very good diuretic, it is a vasodilator. So all the benefits which used to be get negotiated because of this neprilysin, because of this combination, that we have a better option to increase the BNP levels. So that is how it works. This was the paradigm trial where it has been See, and you can see the hospitalization for heart failure was reduced by 21% when, when the RNA was used in comparison with the ACE inhibitors. The death from any cause and death from cardiovascular cause were reduced by 20%. And if you see the ARB, they reduce the heart mortality by 15%, and this RNA, this reduces it by further 20%. So this is all the benefits of the RNA what we are discussing. They have a better effect on the renal dysfunction. They can be given in patients with chronic kidney disease also, but with a caution. They reduce the serum uric acid level as well. So the guidelines say that you can use this RNA in patients with chronic symptomatic heart failure with reduced ejection fraction, even who tolerate an ACE inhibitor. Even the patient who tolerates an ACE inhibitor or ARB, you can use this RNA. And this has been recommended for prevention of sudden cardiac deaths as well. So if we come to the placement of RNA in the heart failure therapy, you can see it has almost equalized or it has advanced beyond the ACE inhibitor or the ARBs. So these are the things which can change the mortality. The hydralazine, S-ascorbyl dinitrate, digoxin and evaporatin, they have only morbidity benefit, no mortality benefit. So then we have the device therapies. Device therapy, I don't want to go further. Device therapies, we have the CRT and CRT-D, where we can put the ICD. These are the AIC devices. They reduce the mortality by 31%. So these are the parameters for CRT. So in heart failure, adding therapies is adding life. So more therapies or more molecules you add to the heart failure patient, the more the benefit to the patient. And you can see evolution from 1989 to 2018. In 89, we used to have digoxin, diuretics, and vasodilators. Now we have ACE inhibitors, RNA, beta blockers, aldosterone antagonists, evaporatin, ICT, implantable devices, mechanical supports, and palliative care. These are the novel agents in heart failure. The patients with heart failure in whom end-of-life care should be considered. If there is a progressive functional decline, severe heart failure symptoms not responding to the treatment, frequent admissions, heart transplantation not an option, cardiac cachexia is there, and clinically judged to be close to life. These are the parameters which decides whether the patient we should continue with the heart failure treatment or not. So by applying all evidence-based discoveries, heart failure is becoming preventable and treatable disease. The great thing in this world is not so much where we stand, as in what direction we are moving. So hearts are like a glass. Be careful, they can break. Thank you. Any questions? No questions means either everything has been understood or nothing has been understood.